Hi, this is Mario,
And Gloria.
and today we're going to be talking about migraine and tension headaches. So first let's take a look at the definitions of the two different type of headaches. First we'll talk about migraine headaches, and these are classified as two different types of headaches. These are migraines without an aura, and they consist of pulsing, throbbing, and unilateral headaches that last approximately 1 to 2 days, sometimes longer, sometimes shorter, and they are typically aggravated by activity, accompanied by nausea and vomiting, and sensitivity to light and sounds, and also contain visual disturbances. Now, migraines with an aura contain the similar symptoms, but as the name implies, has an aura, such as speech disturbances and some sensory features such as pins and needles, and also negative features such as numbness. In addition, they also have visual symptoms such as flickering lights, spots or lines, and negative features such as loss of vision. Now, attention type headaches are not as severe as a migraine. They don't interfere with daily activities that migraines are prone to do. They're described as dull, aching, diffuse, nondescript, and occurring in the hatband area, and they're not associated with nausea or vomiting, and they're not worsened by activity. They can be classified as chronic or episodic. The chronic tension headaches last, there are fewer than 15 within 30 days for 6 months, and greater than 15, and the episodic are less than 15 within a month. Now let's take a look at the epidemiology of migraine headaches. They occur in over 20 million people in the U.S., and in general, both migraine and tension occur more often in women than men, but with migraines, 18% of women are affected and 6% of men are affected. And looking at some of the literature, one of the studies showed that there is an inverse relationship related to income and educational achievement. Now, with tension type headaches, 79% of Americans have experienced at least one tension headache in their lifetime. 2 to 3% of the population are affected by chronic tension headaches, and 43% of women 30 to 39 years of age are affected by episodic tension type headaches. 83% of those with migraine headaches experience tension type headaches, and 8.3% of episodic type tension headaches miss work due to the conditions associated with the headaches, and then 20% of chronic tension type headaches miss work due to the conditions. So looking at the pathophysiology with migraines, this is still a area that is a little understood as far as the pathophysiology. There are several theories. One of the most accepted theory is that the cranial nerve becomes activated. It is thought that the activation of the trigeminal sensory fibers causes the release of neuropeptides, causing painful neurologic inflammation in the meningeal vasculature. Now, this is manifested by plasma protein extravasation, vasodilatation, and mast cell degranulation. Some of the other three theories that are out there is that they're caused by neurological vasodilatation of the meningeal vessels. Another one is a theory that migraines are caused by fluctuation in hormones, and this is thought to be because of women reporting migraines during their menstrual period, and also the fact that the prevalence is higher in women. And the third theory is that dietary substances such as chocolate, caffeine, monosodium gluconate, and aged cheese are triggering these migraines. Now, in regards to pathophysiology with tension type headaches, again, it is unknown. They don't have any definitive pathophysiology answers. But the theories are, one, it results from sustained tensions of muscles in the scalp and neck. Another one is it's a small version of a migraine headache. And it also, they think that it could be oromandibular dysfunction related. Another one is psychogenic stress. It could be caused by anxiety, depression, macular stress, overuse of an analgesic, or overuse of caffeine.
So now it's my turn. This is Gloria, and it's regarding tension type headaches and migraine headaches difference. So as Mario mentioned, tension type headaches are nonspecific, unlike migraine headaches. So tension type headaches, like he said, is basically a tight band around the head type of ache. Meanwhile, migraine headaches are throbbing and pulsing ache-like. Tension type headaches tend to be mild and moderate, unlike migraine headaches, which are severe pain. As he mentioned, tension type headaches are all over the head or bilateral pain. Meanwhile, migraine headaches are unilateral or only on one side of the head. Tension type headaches are not associated or aggravated by any physical activity, or is it sensitive to light or sound. It is also not associated with nausea and vomiting, but migraine headaches are. So when you see a doctor, doctor can basically diagnose with the distinct features of both headaches. They will talk about the chronic or recurrent headaches having a pain or pain characteristic that's pulsating. That's basically your migraine headache, and the ones that's constant and dull will be your tension type headaches, and the sharper stabbing will be your migraine headaches. The pain intensity, are you able to function or go to work? That's basically a tension type headache type of characteristic. But if you need to lie down in a dark or quiet place, that is a migraine headache. The pain location, one side of the head is your migraine headache, and all over is your tension type. And there are different headaches, and when they're very unusual and complicated, the doctor would usually order an image of your brain where they use a CT scan or MRI. Other tests would be a blood test where they look for blood vessel problems, infections in spinal cord or brain, and toxins in the system. Oftentimes, they would also do a spinal tap and where they do a lumbar puncture. They also do an EMG or your electromyography, where they can explore the relationship of the pericranial muscle activity and headache. So the management and treatment of tension headache versus migraine. With tension type headaches, there are pain relievers that they can prescribe or that you can get: aspirin, ibuprofen, or naproxen. And there are also prescription medications such as naproxen, indomethacin, ketorolac. There are also combo medications that you can get, and it's known to be more effective than single ingredient pain relievers such as aspirin or acetaminophen, or both added to caffeine or a sedative drug in a single medication. There are also triptans, which are known to be effective for tension-type headaches. And triptans are your medication used to treat. It's basically an agonist at the 5-HT or the 5-hydroxytryptamine receptors in the brain. And each of the medication has a generic name that ends in triptan. Just to name a few, it's zolmitriptan, almotriptan, provatriptan, naratriptan, rizatriptan, and sumatriptan. There are also narcotics, but they are rarely used due to the side effects and potential for dependency. The migraine headaches, they usually prescribe the pain-relieving medications. For mild, it's your aspirin, your NSAIDs, and acetaminophen. For moderate to severe pain, there are combo drugs where they combine acetaminophen, aspirin, added to caffeine, and this is called the Excedrin migraine for moderate pain. There's indomethacin in a suppository form is given to those who are not nauseated. Triptans, there's a combination that's very good for migraine headaches. It's called a sumatriptan plus naproxen, and this is the brand name is Treximit, and it's like I said, more effective. There are ergots. They're known to be more effective for pain that lasts more than 48 hours, but they can cause medication overuse headaches. There are your hydroergotamine, or your DHE45 or Migranol, an ergot derivative, which is available as nasal spray and in injection form. And these are less likely to cause medication overuse headaches. There's also anti-nausea. As you know, migraine headaches are often accompanied by nausea and vomiting. Reglan and Compro are usually prescribed. And there's your opioid medications, where they contain narcotics such as codeine. And these are usually recommended to those who cannot take triptans or ergots, but they're last resort, again, due to its potential for abuse. So the education and health promotion, they suggest that you keep a headache diary where you can note the date and the duration of the pain, how long it's been, the intensity rated from 1 to 10, the triggers such as certain foods, physical activities, noise, stress, smoke, bright lights, or weather changes have to be noted. The symptoms prior to getting the headache, if you have aura or non-aura, medications, even if unrelated to headaches, make a note of what you're taking. And there's those relief things that you could do which are non-pharmacological, like massage, or if you sleep, or others that help relieve the pain, have to be noted as well. So there's a new study linking obesity to migraine headaches or any type of headaches.
A new study finds people who get occasional migraine headaches are more likely to be obese than people who don't have migraine. Dr. Mark Stillman did not take part in this study, but treats migraine at Cleveland Clinic.
They have a BMI that's either slightly over the normal range or grossly over the normal range.
Johns Hopkins University researchers studied nearly 3,900 people. About 1,100 of them were obese. Results show obese people were 81% more likely to have episodic migraine than normal weight people, and women were even more at risk.
This occurs under the age of 50, mostly in the population under the age of 50, mostly in white versus African American females.
Researchers say the next step is to determine if weight loss programs may help overweight and obese people with episodic migraine. Dr. Stillman agrees.
We certainly recommend people exercise and go on be careful about their diets in a variety of ways, and to go on some sort of weight maintenance program.
Complete findings for this study can be found online in the journal Neurology.
So that's our video. So there are new studies stating that repeated use of over-the-counter medication can cause medication overuse headaches to those who do not seek medical attention. They mentioned that if you are experiencing 3 to 5 or 7 days of popping medication due to headaches to start to see